There we go. Our objectives are to review the risk factors for thrombosis, go through the components and indications for thrombophilia testing. We're going to review commonly used anticoagulants and their mechanisms of action, and outline a practical approach to anticoagulation reversal. I have no disclosures related to this talk. And it's important to recognize that when we talk about thrombosis, that a lot of this comes back to Virchow's triad involving venous stasis, a hypercoagulable state, and vessel wall injury. For hypercoagulable states, it's not just inherited factors. That's what is commonly thought of, but many different factors contribute. And it's also possible for any one of these domains to be contributing to thrombosis all on its own. But if you have overlap in some of these areas, you'll see an increased risk where it's synergistic or additive. Venous thromboembolism, we talk about the risks for hypercoagulable states, including inherited and acquired. And it's actually the acquired that are much more common. For instance, in the United States, 35% of adults meet criteria for obesity, and this confirms an odds ratio for VTE of 2.3. When we look at all patients who have clots, less than 10% of them have an inherited thrombophilia that is contributing. And it's more common for them to be several factors that are additive or synergistic. We also classify clots as provoked or unprovoked. Sometimes we can find a clear precipitating factor, but most of the time this is idiopathic or an unidentified risk factor. It's also important to think about whether these are transient or provoked. And in the terminology you see used in literature and guidelines, you'll see both idiopathic and unprovoked being used interchangeably. The annual incidence of VTE goes up both by age, and there's differences in sex. And as you can see, these pretty much track with each other until midlife, at which point the curves start to go up. This has to do with hormonal changes, the higher incidence of obesity in these populations, and other comorbidities as well. There is some separation in the curves that you can see here, which may have to do with differences in hormones, testosterone, estrogen balance, and its contributions to cardiovascular risk. When we talk about the acquired risk factors for VTE, you can divide them into a couple of categories. The ones that are easy to think about are the transient provoked major risk factors, such as surgery, trauma, acute medical illness, hospitalization that leads to immobilization, use of estrogen, either in oral contraceptives or hormone replacement therapy. Pregnancy is a well-known acquired risk factor for VTE. Heparin-induced thrombocytopenia, and prolonged air travel can contribute, but it doesn't have the same degree of risk as many of the others on this list. When we think about persistent risk factors for VTE, this includes obesity, increasing age, and chronic medical illness. Think about cancers and the different therapies that we use for them. It's not just the malignancy, but also IMiD therapy in multiple myeloma or tamoxifen in the setting of breast cancer. Inflammatory bowel disease, nephrotic syndromes, and myeloproliferative disorders all have associated risks, and sickle cell disease does as well. And this is in contrast to the unprovoked VTE, in which there are probably contributing risk factors, but we haven't been able to identify the major risk factor that contributed to that specific event. In terms of acquired deficiencies, we think about hereditary deficiencies, commonly of antithrombin, but there are acquired deficiencies, such as pregnancy, liver disease, consumption in DIC. Nephrotic range proteinuria causes a loss of antithrombin, and so leads to a hypercoagulable state. Major surgery causes a decrease in protein C and protein S, but also antithrombin as well. And acute thrombosis consumes the protein. It's important to recognize that treatment with heparin or estrogen can lead to lower levels of antithrombin, so it's important to understand the context in which you're testing. Protein C, liver disease, and DIC are some of the common reasons to have low levels here. Acute thrombosis. Warfarin will decrease levels of protein C. And protein S has several others. So you can see there's a lot of overlap here and a lot of things that will contribute due to acquired deficiencies of these natural anticoagulants. Many of the inherited thrombophilias have mutations that create an imbalance in the coagulation proteins. These can be classified as increasing the procoagulant activity. Factor V Leiden mutation leads to a specific point mutation in coagulation factor V that makes it more resistant to activated protein C's breakdown, and so you have resistance to activated protein C. The prothrombin gene mutation increases circulating prothrombin levels. The protein works perfectly fine and has no problem in all the regulatory mechanisms, but as a population, patients with this mutation run slightly higher factor II levels and therefore thought to have a slightly higher risk. And when you look at these, about 50 to 60% of all of the inherited thrombophilia is related to thrombosis are factor V Leiden and prothrombin gene mutation. Several of the inherited mutations will lead to decrease in anticoagulant activity, such as protein C, protein S serving as a cofactor for protein C, or mutations in the genes for antithrombin, which circulates to inactivate thrombin and factor Xa primarily. Now, when we talk about a hypercoagulable workup, this typically includes certain tests. These are the ones that are probably the most common and likely the highest yield in most cases. Many institutions have a hypercoagulable panel, which includes many other tests, but these are the ones that if a patient really does have an indication for hypercoagulable tests, these are the ones that are probably the best to pursue. The test for factor V Leiden can be done either through an assay assessing activated protein C resistance or a PCR confirmation. PCR is available for the prothrombin gene mutation, and the assays for antithrombin, protein C, and protein S are functional assays. Particularly around protein S, it is important to recognize that different labs will measure different things. And so you can get a total amount of protein S, which is your amount that is free, plus the amount that is bound to C4b binding protein. But it's important to recognize that protein S, the anticoagulant activity of protein S mainly comes from the free, and so getting a total level isn't very helpful when what you really want to know is how much is free to provide an anticoagulant effect. The inherited thrombophilias are extremely rare in terms of dysfibrinogenemia. There's also homocystinuria due to cystathionine beta synthase deficiency. We actually recommend against testing for homocysteine and methyl tetrahydrofolate reductase mutations. And this is because there are studies showing that therapy to lower levels with B complex has no impact on recurrent VTE or MI. Many hypercoagulable panels will look at coagulation factor VIII. This is an acute phase reactant, and in most cases is not the cause for the patient's thrombosis. It's probably the underlying inflammation that is causing this to be elevated and conferring risk. Some labs will test for polymorphisms in factor 13 or look at levels of other coagulation factors. These have not been associated with thrombosis, and the same for mutations in plasminogen activator inhibitor 1. What is actually helpful in many cases is an assessment of antiphospholipid antibodies. The lupus anticoagulant, anticardiolipin, and beta-2 glycoprotein are the three antibodies that should be assayed in patients suspected of having an antiphospholipid syndrome. The lupus anticoagulant screen is a functional clotting assay that is sensitive to phospholipid antibodies. And then you do a confirmatory test. And so the way I explain this is it's almost like an HIV test with very sensitive ELISA and a more specific Western blot. The entire process has to be positive for you to say that this is truly a positive test. Anticardiolipin and beta-2-glycoprotein, you have IgG and IgM. Many labs will offer IgA testing. This is not associated with thrombosis in many of the studies, and the contribution of IgA is probably minimal outside of what is detected for IgG and IgM. Therefore, it's only those two isotypes that should be considered. These have to be tested 12 weeks later because they are sometimes transient, and it's sometimes difficult to detect a lupus anticoagulant while someone is on anticoagulation. In general, guidance about thrombophilia testing is that indiscriminate testing should be avoided in the inpatient setting or the emergency department, and that's because patients are receiving medications or anticoagulation that can affect these tests. The inflammation from the acute thrombosis or pneumonia when these patients have it, and that's contributing, can also affect these tests. And you have to think about what's the quality of the lab that's running the test. Is it a lab that does this frequently? It's also important to think about how it's going to change management. If I tell you somebody has factor V Leiden on day 5 of their acute thrombosis, is it going to change your acute management? Well, you're still going to treat that patient for a minimum of 3 months. So knowing at day 5 versus after day 90, once you've made a full assessment of family history, rarely ever changes your clinical management. What should you think about in terms of the inherited thrombophilia as well? For patients who have clots at very young ages, age of onset less than 50 years, patients who are having recurrent thrombosis, particularly in very specific settings, if there's a positive family history in first-degree relatives. So I'm often asked in the clinic about getting inherited thrombophilia testing in somebody who had a provoked thrombosis. And I often go through a history and find out that no one else in their family has had clots. And they've probably had multiple thrombotic challenges, use of OCPs, pregnancy, multiple surgeries before. And so in patients who truly have inherited thrombophilias that are contributing, you generally see the family history pattern. Unusual locations and sites can sometimes be a clinical clue. For instance, cerebral vein thrombosis is more common in patients with the prothrombin gene mutation. When we think about sites of thrombosis, it's also important to recognize that most of the hypercoagulable tests, certainly the inherited thrombophilias, increase the risk of venous thrombosis, but have negligible or no effect on arterial thrombosis. That's in contrast to the antiphospholipid antibodies, in which you see both arterial and venous thrombosis. When we also think about the inherited thrombophilias and risk, it's important to recognize that most patients that have an inherited thrombophilia will never have a blood clot, and most patients that have blood clots don't have inherited thrombophilias. And so when you see here, you can see that patients who are heterozygous for factor V Leiden, this is fairly common in the general population, and there's a wide range of relative risks, but the absolute annualized risk of that first VTE is very low. In addition, factor V Leiden does not increase the risk for recurrent thrombosis. This is in contrast to patients who are homozygous for factor V Leiden, who have very high rates of thrombosis, approaching almost 1% annualized risk. And again, you typically see this as patients who have thrombosis at a very young age, oftentimes with minimal provocation in a hormonal setting. As you can see going through, you'll see various percentages. Most of these are very low, less than 1% per year. But in patients who have protein S and protein C deficiencies, these patients do have a significant thrombosis risk. It's not very common in the general population, but they have a high risk. And that goes along with antithrombin deficiency, which probably has one of the highest risks for thrombosis of the inherited thrombophilias. So who do I test for inherited thrombophilias? Well, again, patients with VTE at a young age with positive family history and first-degree relatives, unusual sites, cerebral venous thrombosis. For portal and mesenteric vein thrombosis, I actually lean more towards a myeloproliferative disorder or a clonal disorder with PNH rather than inherited thrombophilias. And I tend to think about recurrent pregnancy loss, antiphospholipid syndrome, but also we do see this with some of the inherited thrombophilia. It's reasonable in patients who have VTE associated with hormonal therapy or pregnancy. I tend to focus on factor V Leiden in that case, or young age with minor provoking risk factors. Somebody who's 20 or 30 years old and went on a plane ride cross country, most people do fine with that, so it seems that there's maybe something contributing. People who are over the age of 50, I avoid it. Certainly patients with malignancy. I do not do thrombophilia testing in postoperative patients or those with retinal vein thrombosis. And certainly I avoid it in testing in women who go on oral contraceptives without a family history of VTE. I will consider it in someone who has not had a VTE event if there's a strong family history and first-degree relatives and we're considering estrogen therapy. And why is this? Because the role of testing is not well defined. We really don't have good data on utility and the efficacy and safety of prophylaxis in many of these situations. And again, it keeps coming back to when does it change care? Is it going to explain the etiology? Are we going to consider prophylaxis in pregnancy? One of my common consults are women who have had testing because a family member tested positive for factor V Leiden. They themselves have never had a thrombosis, and then they're referred because their obstetrician insists that they be on prophylaxis during pregnancy, even though they've had successful pregnancies before. We think about it when it changes care in family members. So if I have a woman who has a thrombosis and she has a daughter who's considering estrogen, I will sometimes test the patient so that information can be used in counseling. And when does it not change care? Well, duration of therapy. Really, you should be using whether this is a provoked major transient risk factor or unprovoked or a risk factor that cannot be reversed. Certainly, the presence of inherited thrombophilias does not change what we do in malignancy or the antiphospholipid syndrome. So what factors do impact duration of anticoagulation? Well, the most significant factor is the etiology. The transient risk factors such as surgery, an intravenous catheter, for instance, determines length of anticoagulation. Patients with malignancy, if they have a malignancy-associated thrombosis, generally 6 months is enough. And then you can think about do they still have active malignancy or receiving cancer-directed therapy? Somebody with an early-stage cancer, resected, treated with adjuvant chemo, no evidence of disease, very easy to consider taking them off. Patients with metastatic disease receiving ongoing palliative chemotherapy, somebody I would keep it on. And the presence of an inherited thrombophilia does not mandate indefinite duration anticoagulation. It requires a discussion with the patient about risks and benefits of extended anticoagulation with shared decision-making. And when you look at VTE recurrence risk, well, if this was a cohort of 570 patients followed for 2 years after their initial treatment, and there was no difference in recurrence based on thrombophilia status. what did predict risk was the situation that provoked it in the first place. So patients who had a post-op VTE in the first 6 weeks had no increased rates of recurrence, whereas patients with unprovoked thrombosis had rates as high as 20% at 2 years. When we look at non-surgical risks, so these are our medical conditions. If you think about it, CHF, chronic kidney disease, obesity, it falls somewhat in between. And so these are the major transient risk factors. These are the major transient risk factors. These are unprovoked, and these really require a discussion. And so in summary, hypercoagulable states a spectrum of risk, with many patients having multiple additive risk factors. Both the environment and acquired events add to the baseline genetic risk and is much more important than the inherited thrombophilias. And they may provide a variable baseline risk, but testing is easy, but knowing what to do with the results is not. And no guidelines have been established yet. There are guidelines in development from specialty societies. And whenever there's a question, consulting with a thrombosis and hemostasis specialist can be very helpful to understand an individual patient's risks. At this point, I'm going to switch a little bit to anticoagulation, talk about the common parenteral anticoagulants that we have. All of us are familiar with unfractionated heparin, low molecular weight heparin. We have the synthetic pentasaccharide fundaparinox, the direct thrombin inhibitors, warfarin available here in the United States, and then the oral direct thrombin inhibitors, dabigatran. And when I think about factor 10A inhibition, one of the ways to remember is the drug a 10A inhibitor. It has XA in its generic name. And so I say the specifically generic name because unfortunately dabigatran's brand name has an XA in it. But if its generic has XA in it, odds are it's a 10A inhibitor. Warfarin is not an anticoagulant on its own. If you take warfarin and you take a blood specimen and you put warfarin into it, it has no anticoagulant effect. It's only its effects on vitamin-dependent gamma carboxylation, vitamin K-dependent gamma carboxylation in the liver to create coagulation factors that function or are dysfunctional. And so usually you start at low doses. High doses increase the risk of thrombosis and tissue gangrene. Adjustment generally takes 3 to 4 days to see an effect. When you start at 100% of a factor, within 2 days, factor 7 has dropped down to levels that will cause a prolongation in the INR. The INR is very sensitive to the level of factor 7. However, as you can see, prothrombin and factor 10 have much longer half-lives and are still around. So even this is why patients with a therapeutic quote-unquote INR in the first couple of days are still very hypercoagulable, and you need to overlap them with something else such as low molecular weight heparin. Heparin itself is a variable molecule. You have unfractionated heparin, which are very long and actually change the functional configuration of antithrombin to make it better fit the shape of the factors it's going to inhibit. The reason that low molecular weight heparin doesn't have as much of an effect is because it's not as long to bring thrombin in to antithrombin. And when you look at this, fundaparinox is just this pentasaccharide sequence at the end, which causes the conformational change for antithrombin. But all of the heparins work through antithrombin for its anticoagulant effect. The dosing varies in once or twice daily, depending on the prophylaxis or therapeutic dosing. What's great about dalteparin is that it's once daily, no matter what your indication is. Enoxaparin, really, if it's prophylaxis, should be given daily. I tend to avoid the once daily enoxaparin dosing. It leads to very high peaks that can cause bleeding and then low troughs that increase the risk for thrombosis, especially if patients miss their dose. Fundaparinox is also once daily and has a pretty straightforward dosing regimen based on weight. The factor 2 inhibitor, dabigatran, has different dosing for stroke prevention in AFib or VTE. In VTE, you have to treat with a parenteral agent for the first 5 to 10 days, then you can switch to oral. You need to be very careful with creatinine clearance for dabigatran, and particularly if being used for VTE. The factor 10A inhibitors, rivaroxaban, apixaban, and edoxaban, have really taken over the market, have indications for prophylaxis in knee, hip, stroke prevention, and AFib. In therapeutic, it's important to recognize that the rivaroxaban dose is 15 twice daily for 21 days, then 20 daily. After 6 months, you can decrease this to 10 daily based on the data from Einstein Choice. For apixaban, it's 10 milligrams twice daily for 7 days, then 5 twice daily. After 6 months, you can decrease this to 2.5 milligrams, again, twice daily, based on the Amplify extension study. And edoxaban, just like dabigatran, requires a parenteral agent the first 5 to 10 days, and then the dose is based on weight. There are no data for dose reduction after 7 or 6 months in this population. And these are being increasingly used in patients with malignancy based on Hokusai, VTE, SELECT-D, and Caravaggio, which have been published over the last several years. There are some cautions with the direct oral anticoagulants. The International Society on Thrombosis and Hemostasis recommends avoiding DOACs if you have a weight greater than 120 kilograms or BMI greater than 40. And that's because patients in these weight ranges were not well represented in the clinical trials. There's some subsequent real-world data that suggests possibly a BMI up to 50 may be okay and higher. Some are advocating for use of DOAC-specific anti-10A levels or drug levels. We don't have data about the clinical efficacy and safety of that, but it is being used more frequently. In mechanical valves, it is contraindicated, although there is discussion about a new trial using one of the DOACs to look at this. In the antiphospholipid syndrome, I have contraindicated here in quotes, mainly because of triple positive disease. We have a trial that was published in Blood in the last several years called the TRAPS trial, which compared rivaroxaban to warfarin, and they had to stop this study early due to increased rates of thrombosis, particularly arterial thrombosis, like stroke, in patients on rivaroxaban as compared to warfarin. There are a lot of people who have single and double positivity, and we do not know the clear risk-benefit balance. And I tend to avoid it in patients who have undergone most types of bariatric surgery, partially because many of these patients still have weight outside the range, but for absorption issues. When you look at the different types of surgeries that can be performed, you can have very significant Roux-en-Y. You can have laparoscopic sleeves. You can have sleeve gastrectomy. But if you look at where most of the DOACs are absorbed, it's usually in the distal stomach, the duodenum, and the proximal jejunum. For instance, apixaban here in yellow is mainly in the duodenum and the first part of the jejunum. Whereas you look at rivaroxaban, it is primarily here in the stomach with some little bit more distal. And so given variable absorption, uncertainty about clinical efficacy, I tend to avoid DOACs in bariatric surgery settings. In terms of reversal, we've become more comfortable with many of the options. We can give PCCs that have varying degrees of proteins in them. There's activated PCCs as well, recombinant factor 7A. FFP is listed, but generally doesn't have the same efficacy as some of these other strategies. We now have specific antidotes, a monoclonal antibody fragment against dabigatran known as idarosizumab, and then we also have the factor 10A derivatives, andexanet alpha. And for some patients, they may require dialysis, You can use desmopressin, and antifibrinolytic agents can be used supportively, especially if it's an area with mucosal bleeding. I'm going to show you these data with the caveat that just within the last week or so, there was an update to this consensus pathway on the management of bleeding in patients on oral anticoagulants. It is the same from 2017 to now, with the exception of one section of one figure, which I will point out. And so the first thing that's important, do one of the following factors apply, is the bleeding at a critical site. And these critical sites include intracranial hemorrhage, CNS bleeding, tamponade, airway bleeding, hemothorax, or extremity bleeds. Are they hemodynamically unstable, or are you seeing a drop in hemoglobin greater than 2 grams from baseline, or they needed more than or 2 or more units of red cells? If so, that is a major bleed. Otherwise, this is a non-major bleed. Well, if you have a major bleed, you go through, and in all cases, you'll see all the way across stopping anticoagulation. Initiate appropriate measures to control bleeding. If it's an area that you can apply pressure or go in procedurally to stop the bleeding, that can be very helpful. If this is a major bleed at a critical site or is life-threatening, that is when reversal agents come into play. Or, if you don't really have your measures to control bleeding didn't work, and you continue to have ongoing bleeding in spite of supportive care. Thinking about when to use assays, and think about, does the patient even have drug on board? Most of these assays are not available in routine clinical practice, but if you, for instance, if you have a normal dilute thrombin time, eccrine clotting time, or chromogenic assay, you can probably exclude dabigatran levels. If you have an absent anti-10A activity, it probably excludes clinically relevant levels of apixaban, edoxaban, and rivaroxaban. When you don't have these assays, you can try using the PTT or PT, with the understanding that these assays are not as sensitive as some of the others in trying to exclude bleeding. This is the figure that has changed in the 2020 update. It is the same for vitamin K antagonists with using 4-factor PCCs. There are low-dose options that are available, and if the PCCs are not available, at which point you consider using plasma. For dabigatran, it still continues to recommend idaracizumab, and if that is not available, 4-factor PCCs, and if it is a recent ingestion, you can consider activated charcoal. For the factor 10A inhibitors, the new table pulls out apixaban and edoxaban and adds in the first step use of andexanet alpha before continuing on to this chart. For for apixaban and rivaroxaban, those are the only ones for andexanet alpha. Edoxaban was not included in the FDA approval for andexanet alpha, so edoxaban, you go straight to this. For apixaban and rivaroxaban, you use andexanet alpha. And you have to think about restarting anticoagulation. Obviously, most of these patients had a reason that they were on anticoagulation in the beginning. So did the bleed occur at a critical site? Are they at the high risk of rebleeding? Have you identified the source? Are there other procedures planned? And what does the patient think? This is an area for shared decision making, and that you can make a decision about delaying the restart of anticoagulation or being able to restart it given the prior indications. And so in summary, anticoagulation, we have many options. DOACs are first-line therapy for most indications. You need to think about renal function and obesity and absorption, particularly in the setting of bariatric surgery. And reversal should be reserved for life-threatening bleeding. And so with this, I'm going to move on to our 2 audience response questions. Question 1. A 58-year-old man presents to the emergency room with diarrhea with bright red blood. He is known to have diverticulosis based on screening colonoscopies and was recently started on apixaban 5 milligrams twice daily for atrial fibrillation. The last dose of apixaban was 6 hours ago. He is hemodynamically stable with hemoglobin just 1 gram lower than baseline. Treatment should involve A, transfusions with 4 bags of FFP, B, idarosizumab, 5 grams IV bolus, C, IV vitamin K, D, aggressive supportive care with IV fluids and red cell transfusions if necessary, or E, andexanet alpha according to the package insert. So far, over 100 of you have voted. Of the 360 some who are online currently. Okay, I'm going to give it a few more seconds and then we'll move on. So it sounds like the vast majority of people have chosen D, aggressive supportive care with IV fluids and red cell transfusion if necessary, with a few people choosing andexanet alpha or transfusion with 4 bags of FFP. And the answer, as most of you checked, is aggressive supportive care with IV fluids and red cell transfusions if necessary. So the patient does have bleeding and has known diverticulosis. He's on a direct oral anticoagulant, but he's hemodynamically stable. His hemoglobin is about 1 gram lower than baseline, so doesn't meet criteria for a major bleed. And as long as he remains hemodynamically stable, usually just holding the anticoagulant is enough to stop. It has a very short half-life, and so many times by the time you get the patient into the emergency room, get their evaluation, and were to think about the drug, most of the drug may have actually metabolized out. We're going to go to the next question. Question 2 is a 67-year-old man seen by his primary care physician for advice about duration of anticoagulation. 2 months ago, he had urgent cholecystectomy and developed a left calf vein DVT. The surgical team sent a hypercoagulable workup which revealed he is heterozygous for a factor V Leiden mutation. What is appropriate management approach to management? A, treatment for 1 additional month. B, treatment for 3 additional months. C, lifelong anticoagulation. D, stop the anticoagulant at this time. We've got about 100 people who have voted so far. If you haven't, I'll give you about another 15, 20 seconds. So it looks like the majority of people have chosen A, treat for 1 additional month, which would be a total of 3 months of anticoagulation. And some are advocating for 3 additional months for a total of 5, some for lifelong, and some say just stop the anticoagulant at this time after 2 months. So I'm going to end it here, and we're going to go to the answer, and it's for treat for 1 additional month. So this is a patient who clearly has a provoked deep vein thrombosis. He was inflamed, underwent surgery. This is provoked by a major transient risk factor, and current guidelines suggest treatment for about 3 months would be appropriate. Unfortunately, we have this information here that he's heterozygous for a factor V Leiden mutation. He has had this all his life and has only had a clot in the setting of a provoking event, and so this should not be used to determine length of anticoagulation. So treat for 1 month and stopping anticoagulation would be appropriate. And with that, I will leave it for my references, and if we have any questions, thank you.
Great, Nickman, thank you. So we have several questions around the same issue. which is what parts of the hypercoagulable workup can be done for a patient who's already on anticoagulation in various iterations.
Yeah. So what can be done? So typically, if you think about it, any test that is a PCR, so prothrombin gene mutation, patients who get PCR for factor V Leiden, that is reliable. The functional assays, protein C, S, and antithrombin should be avoided while on anticoagulation. Lupus anticoagulant testing should be avoided while on anticoagulation. And then finally, in the setting of acute thrombosis, sometimes you see the inflammation has driven a borderline positive ELISA for the cardiolipin or beta-2 glycoprotein antibodies. So I tend to avoid that. Honestly, if I'm thinking of that I'm going to use the results for something and I want accurate results, I take the patients off. At least a week to 10 days on warfarin, or 48 to 96 hours off the DOACs.
Okay, so how long before procedures do the DOACs need to be held?
So there are some interesting data about this. Some of the best data actually come from the atrial fibrillation literature. We have the PAUSE-AF trial that was presented and published in at the American Society of Hematology about a year and a half ago and published within the last year. In general, it depends on the bleeding risk of the procedure and the patient's renal function, particularly around dabigatran and rivaroxaban. Usually it's a minimum of 24 to 48 hours, depending on the bleeding risk, and sometimes, particularly if they have poor renal function or it's a high-risk bleeding procedure involving the CNS, for instance, you can hold it 72 to 96 hours, but it does have to be individualized for each patient within those guidelines.
Great. If a patient has heparin-induced thrombocytopenia, can you use factor Xa inhibitors?
It's a great question, and there have been some small trials. There was a phase 2 study that was looking at this. A lot of us are feeling more comfortable using it. They are not FDA approved at this time for that indication, but they are a reasonable option in patients. I would stick to the guideline therapy in patients that are in the early stages, using bivalirudin, which is actually not FDA approved, or argatroban, which is potentially using fundaparinux until their platelet count is normalized and they've stabilized, and then you could consider a DOAC on a case-by-case basis.
Okay. What anticoagulation do you recommend for bariatric surgery patients, especially those who are on multivitamins?
Yeah, so in the acute setting, so in the post-op setting, I do generally recommend an escalated dose of prophylaxis depending on BMI. So for patients with a BMI between 40 and 60, I'll use 40 BID. BMI greater than 60 at the time of surgery, I'll use 60 BID just because of distribution. The great thing about warfarin is that you can dose titrate it to the anticoagulant effect. So if they're on a stable multivitamin that has vitamin K in it, you can use a higher dose of warfarin. So it's a great way to actually get the level of anticoagulant that you want without worrying, as long as they're taking everything in a similar fashion each day.
Great. And one last question. Are there data for using DOAC for 48 hours during prolonged overseas air travel for people at higher risk for VTE or with history of prior VTE?
There are none, and many of us do it. And so it gets used quite frequently, particularly around air travel. We have very little data to guide what we do. Most of it is preference. We used to use enoxaparin in a lot of patients so they could take 1 dose or 2 doses and be done. And now we use the DOACs. It's important to recognize that for patients that are traveling and are going to potentially be scuba diving, for instance, you have to be very careful about the timing between their anticoagulation education and their scuba experience. But that's about it that we have in terms of guidance.
Great. Thank you very much.
Thank you.